Sure. So as you know, there are two relatively new, actually they're not brand new anymore because they were published in 2022, relatively new classification systems for hematolymphoid malignancies. These include the WHO, which is the World Health Organization classification. This is the 5th edition. And then the ICC, which is the International Consensus classification. There's a lot of overlap between the two classifications, but there are some differences. Both classifications heavily emphasize the importance of genetic and genomic classification of both myeloid and lymphoid diseases, but more so for myeloid. And so the field, both classifications have moved away from really basing the diagnosis of acute myeloid leukemia on a numerical blast threshold and rather emphasize the importance of genetics. And so now we have certain genetic alterations that are acute myeloid leukemia defining regardless of the blast count. Examples of these include NPM1 mutation, KMT2A, formerly known as MLL translocation. The WHO recognizes NUP98 rearrangements as acute myeloid leukemia defining. And then one of the differences between the two classifications is that the WHO, for these genetic aberrations that I just noted, they have completely eliminated the requirement for a blast count. The ICC still requires a 10% blast count. And then one of the major differences between the classification is the ICC recognizing a novel category of what they call MDS/AML for cases that don't have AML defining genetics, but have a blast count that is between 10 to 20%. And this is in essence to allow for treating patients with increased blasts with myeloid neoplasms as you would treat an acute myeloid leukemia. But I think the WHO, specifically notes that if the physician prefers to treat a patient with MDS and increased blast count in the range of 10 to 20, they can appropriately treat as AML. For MDS, pretty much the same. There's emphasis on genetic classification. Both the WHO and the ICC have introduced a distinct category of genetically defined MDS. There are some subtle differences, but I'll just go over the major categories, which is pretty much the same in both. One is MDS with isolated deletion 5q. The other is MDS with SF3B1 mutation. Again, with the caveat that the WHO recognizes the category of MDS with ring sideroblasts as a distinct category related to this SF3B1 mutated, even if SF3B1 is wild type. And then both recognize a distinct category of MDS with multi-hit or biallelic TP53 alterations. And this essentially includes myelodysplastic neoplasms or myelodysplastic syndromes that have functional loss of both copies of TP53.